Welcome to our first TAD Talk of 2023. From all of us at the NFOSD, we'd like to wish you a happy and healthy new year, and thank you for joining us this evening. My name is Elizabeth Daly, and I'm the Executive Director for the National Foundation of Swallowing Disorders. If you've joined us before, you'll know that our TAD Talks are usually moderated by NFOSD President Ed Steger. Ed is unable to join us this evening, but know that he is healthy and well and will be back for our next TAD Talk. I have a few housekeeping items to discuss before we begin this evening. You will be muted throughout the presentation, but you're invited to submit a question using the question box in your toolbar at any point throughout the presentation. Nancy has kindly shared a copy of her slides, which can be downloaded from the handout section of your toolbar. We do have permission to record this evening's broadcast and plan to make it available on our website to view later this week. No ASHA CEUs are available for this presentation. However, you will receive a certificate of participation after tonight's broadcast. At the NFOSD, our mission is to improve the lives of those impacted by swallowing disorders. And one of the ways in which we do this is by providing support and education to help people with dysphagia and their loved ones advocate for the proper services. It's important to our foundation that this support and education be accessible, which is one of the reasons why we do not charge a fee to attend our educational events like these. Thanks to the generosity of an unrestricted educational grant provided by Bracco Diagnostics, and thanks to the donations from our community, we continue to be able to offer these presentations for free. And now it's my absolute pleasure to introduce tonight's volunteer speaker, Ms. Nancy Swigert. Nancy's lifetime accomplishments warrant far more than a one-slide introduction, but I'd like to highlight a few of these now. Nancy is a life member of the American Board of Swallowing and Swallowing Disorders, board certified as a swallowing specialist. She chaired the American Board of Swallowing and Swallowing Disorders from 2012 to 2014, and also served as president of the American Speech Language Hearing Association in 1998. She is the president of her consulting company, where she continues to teach and write on pediatric and adult dysphagia, with a third edition of The Source for Pediatric Feeding and Swallowing to be published this year. Nancy has served on the NFOSD's Medical Advisory Board since its inception, providing guidance to clinicians and support to our community. She frequently volunteers to moderate both our adult and pediatric virtual support groups and reviews new content for the Foundation's website. Nancy is such a valued member of the NFOSD team, and it's my honor to turn this presentation over to her.
Thank you so much, Elizabeth. And I am excited to say that I heard from the publisher this week that that book is finally coming out. Those seem like interminably long.
Excellent. I'm excited to hear that. Right. Excellent. We can see your screen here, Nancy.
Let me see if I can make it full screen.
Right. Yes, you are good.
Great.
Thanks.
All right. Perfect. Perfect. Well, this evening, or whenever you're watching the recorded version, we're going to try to provide some tips today for making the most of your dysphagia team. So we're going to go over some basics of anatomy and physiology of three of the main phases, oral, pharyngeal, and esophageal. I'll give a couple of examples in those phases. In no way is this meant to be a comprehensive lecture on anatomy and physiology. We're going to spend time on talking about the professionals that are involved in managing dysphagia, some tips on how you find the right professional for you, how do you judge qualifications. We'll talk about swallowing centers versus individual providers. We'll mention second opinions. We'll cover tests, some of the tests and procedures that are used, and then provide some tips on preparing for a medical appointment, and also what to do if the cause of your problem is not identified. And I did include that because I've heard that several different times from individuals in some of the support groups. And also, how do you identify an ongoing treatment team? Now, a couple caveats. I know we have practicing speech-language pathologists on this webinar. And for you, much of this will be a review for sure. But I do hope that some of the things we go over for consumers will kind of remind you as a provider oh, I should make sure I'm helping the consumers get this information. And for students learning about dysphagia, the same caveat holds true, is that this talk is geared towards consumers, towards individuals and their loved ones, individuals with dysphagia and feeding and swallowing problems and their loved ones. But we hope that it will be helpful for you as well. And also that the terminology and the processes described are those that are used in the United States. And I know that we have individuals who will watch this webinar who live in different locations. And so you'll need to adjust the information based on the medical system in your location, cultural preferences, etc. I'm going to try to hit on both pediatrics and adults because much of the information applies to both. It applies to adults and their loved ones, and it applies to kiddos and their caregivers as well. Most of anatomy and physiology is the same for both of these populations. There are obviously differences in infants. By the time a child's about 6, they have swallowing that's pretty much like an adult's. The professionals involved are pretty much the same, although there might be a specialty that was, for instance, pediatric gastroenterology versus gastroenterology. The tests and procedures, for the most part, used in both of these populations are the same. How you prepare for a medical appointment, how you keep track of medical records, what to do if the cause isn't identified, how do you work with an ongoing treatment team. Most of those things will apply equally to both adults and pediatrics. Now, there are differences. Obviously, the pediatric client has differences in anatomy, particularly when they're very young, and they may present with feeding disorders, not just dysphagia. So by dysphagia, I mean once the food is in the mouth, manipulating it and swallowing it safely, that is dysphagia, whereas with feeding disorders, children often have difficulty with even putting the food in their mouth because of texture problems, problems with self-feeding, food aversions, etc. With peds, most causes are congenital, whereas with adults, most causes are acquired. And with adults, most causes can be identified because typically what has happened is that there's an adult who swallowed normally his or her whole life and something happened. They had surgery, they had radiation, they had a neurological event. It's a little harder with kids often to identify what the specific cause of the feeding disorder or the dysphagia is. With adults, problems in the pharyngeal phase, for the most part, can be treated, but a lot of those techniques can't be used with kids because some of the techniques are hard to do. You know, take a breath, hold your breath, let a little out, swallow hard. I mean, unless the child is pre-adolescent, they probably can't follow the complex directions and apply them consistently. And another change, I think, with pediatrics is treatment often focuses more on the whole body, on the child's positioning and their trunk control, their head control, etc. And we probably don't have that focus nearly as much for most adults. We should remind ourselves that swallowing has to be both safe and efficient. So a safe swallow is a swallow where food and liquid are swallowed and they don't go in the airway and end up instead in the stomach where we want it. Mostly this applies to things happening in the pharyngeal phase, which I'll show you in a bit. Although some problems in the oral phase can send the bolus into the airway. An efficient swallow is one in which the person is able to eat and clear the mouth and clear the throat, and there's not a lot of residue hanging around that might fall into the airway, and they can do this in a reasonable amount of time. And it shouldn't take an hour to eat a meal, for example. So let's do a little review of anatomy and physiology. There are 4 phases of the swallow: the oral preparatory, the oral, you'll hear it called oral transit or oral voluntary, pharyngeal, and esophageal. And they're not distinct. It isn't like, oh, that phase stopped, now I see the next one start. It's very continuous. Oral prep is just what it sounds like. The food is in the mouth and you're prepping it to get ready to swallow it, chewing it if it needs to be chewed, getting it on top of your tongue. The next phase is when you push it back in your mouth. As soon as it leaves the mouth and goes in the throat, that's the pharyngeal phase. That's the phase where it could possibly enter the airway, and then esophageal is once it enters the esophagus. So as we said, this oral preparatory phase is it's controlled very much by the lips, the cheek, the tongue, the soft palate, and the bolus, the ball of food, the bolus, has to be placed on the top of the tongue. Liquids are typically easier to control in the oral phase, and solids need to be chewed and then recollected and put up on top of the tongue. Any problems with motor movements, muscle movements in any of these lips, cheeks, tongue, soft palate, and I don't have dentition there, but teeth as well, can cause problems with the ability to get that food ready to swallow. This is just a little video that'll kind of show you what an oral preparatory phase might look like with an adult. So good lip closure to remove the food from the spoon, able to transfer the food from the tongue over to the chewing surfaces, and you can watch how the jaw doesn't just move up and down, but it's a little bit of a rotary movement. The ability to move the food from one side to the other and collect it on the top of the tongue for a swallow. With children, certainly there can be many problems in this phase with tongue control that's not as precise and developed. We can have loss from the front of the mouth as well.
Nancy, it's Elizabeth. Can I
Yes.
jump in for just a second? Are you able to turn on your video camera by chance?
I probably can.
And it's up to you if you're comfortable with that.
Surely.
Excellent.
How's that?
Now we can see you. Thank you, Nancy. I appreciate it.
Yep. Let's see if I can move it kind of out of the way there for me. Okay. So once it's on the top of the tongue like that, then we move into the next phase where we're going to push it back over the tongue. So now the parts of the mouth that become important are the cheeks to hold it there so it doesn't get down into the cavities, the sulci on the sides. The soft palate has to stay tight against the tongue until we're ready to push the bolus over. And the tongue is so important for squeezing that bolus and putting it over the back of the tongue into the next phase. Now, what can go wrong with those? Well, obviously, anything that changes that oral structure. So congenital differences, surgery to the head and neck, effects of radiation treatment for head and neck cancer can significantly change how those things move. And if the anatomy changes, so for instance, if you've had surgery with partial removal of part of the tongue, obviously that's going to impact how those parts of the mouth move. Neurological changes, because neurology impacts all of our movements. So if there's neurological damage, as for instance in cerebral palsy, stroke, Parkinson's, MS, it can impact the control of all those movements. Now the pharyngeal phase is the next phase, and that's once the bolus leaves the mouth. So the soft palate, I'll show you this in an animation in just a second, lifts up, and it does that so the bolus doesn't go up into the nose. Then the tongue squeezes really hard on the bolus to push it over. And then a whole lot of stuff happens at the level of the larynx or voice box. Lots of intricate movements of little muscles, vocal folds, and cartilages coming together and tight, real tight, and then the whole thing kind of lifting up out of the way to keep everything out of the airway. Now, I want to point out, as we've talked about the oral and the pharyngeal phases, that those muscles that I'm talking about, the ones in the tongue and the lips and the cheek and the ones in the throat, are striated. All that means is striped. It's a certain kind of muscle, but it's important for us to know that because those muscles are under voluntary control. Just like your biceps or your triceps, you can go to the gym and work out and you can change the configuration of the muscle, get a little bit more definition because they're striated. And so with therapy, we can sometimes teach muscles in the throat and the mouth to act differently. And that's important to know because when I talk about esophageal, we're talking about totally different kind of muscle. All right, so I'm going to show you this animation, but let me point out some things. Elizabeth, can you see my little pointer on the screen?
Yes.
Okay, good. All right, so this is the soft palate. You can see how it hangs tight against the back of the tongue to keep the yellow stuff's the corn that the guy chewed. And this, I like this view too, because I think when we think of the tongue, we think of just the little part in our mouth, but look, the tongue is big. It's way down here under the chin. This whole thing is the tongue. This is the epiglottis. Here's the entrance to the airway. These are vocal folds. And you'll watch, these are some cartilages that are going to tip forward. This whole thing is going to kind of lift up, move forward, and get out of the way so that the bolus comes down to the esophagus and does not go into the airway. Now, this animation is a bit herky-jerky. The timing is certainly not like it really is in an adult, but I think it gives a good idea of how complex the movements are. So it starts with the squeeze at the front of the tongue. You can watch the soft palate here start to lift so things don't go back up into the nose. And the tongue kind of strips and squeezes this bolus. And then we see movement down here with everything kind of getting out of the way and pulls open so that it can be squeezed. And look how powerful the tongue is. It squeezes, the back wall of the throat squeezes and pushes the bolus down into the esophagus where we want it to go. Then everything opens back up and relaxes so you can breathe again. So this is the trachea, and you breathe up through your nose, or you can also breathe through your mouth. Now the esophagus. The esophagus, you saw it a little bit on that animation. It's a muscular tube. It's about 8 inches long. It has very moist pink tissue called mucosa, and it's behind the windpipe. You saw that, and hard, and it's in front of the spine. And then right before it goes in the stomach, it passes through the diaphragm. Looks kind of like this. It has a sphincter at the top and one at the bottom. And think of a sphincter like, you know, a little bag that has a string that you tie and pulls like that. Those muscles right there are striated. We talked about those muscles. You can put them under some voluntary control. So the lower and the upper are under some voluntary control. Not to be gender specific, but little boys in elementary school love to show that they can belch on purpose. They think that's a cool trick. I suspect some girls think it's cool too. And that's because they can control this muscle here and belch on purpose. But the rest of this stuff is smooth muscle. So those sphincters keep air from going into the stomach every time you breathe. And it stays closed when you're swallowing, and it'll open up unless you're belching or vomiting or swallowing. But when you're not, when you're just breathing, they're going to stay closed so the air doesn't go in your stomach. That would be very uncomfortable. All right. Now the lower esophageal sphincter, we said that's right where it meets the stomach. It also, let me pop back up so you can see, it also, so the stomach's down here. So that the job of that sphincter is to keep acid from coming back up into the esophagus. Lots of us have that, right? We call it reflux. So that its job is to stay closed until the food gets there. Lots of things can go wrong with the esophagus, and I'm not going to go over all of these, but look at the different things that can happen that cause swallowing problems. We can have spasms, which are very uncomfortable. Things can get stuck. The most common foreign body to get stuck is like compacted meat. There can be webs, little tissue grow across it. You can have reflux disease. And most things with the esophagus are going to be treated medically and perhaps surgically. But again, that's not one that I'm going to be able to, as a speech language pathologist, to teach you an exercise, for the most part, let's say, that would change anything. We do know there's one exercise called the effortful swallow that will sometimes help move things through that esophagus. But esophageal dysphagia is a very complicated thing, much harder to treat, and sometimes it's not. So who might be involved in treating dysphagia, and where do you start? So if you have a problem with swallowing, the first place you start is with your primary care physician. Now, if you're the caregiver for a child, that's going to be the child's pediatrician. As an adult, it might be a family practice specialist or an internal medicine physician, whoever the primary care physician is. Now, if the primary care physician, that's what PCP stands for, is not sure where to start, then a logical place to start with an oral or pharyngeal dysphagia would be to see a speech-language pathologist for what's called a clinical swallow evaluation. And we'll talk more about speech-language pathologists in just a bit. But this would be an initial look, a good history taken to describe what the problem is, when it occurs, what makes it better or worse. And that would be a good place to start if your physician says, I'm not sure who to send you to first. But there are tons of medical professionals that might be involved in the care of an individual with dysphagia or with a feeding disorder, physicians and physician extenders like physician's assistants or nurse practitioners. So let's touch on some of them. So a gastroenterologist, and again, I said that you might, if it's a child, then it might be a pediatric gastroenterologist. Some of these specialists are hard to find, particularly if you don't live in a big metro area, and finding one that specializes in pediatrics can be even more challenging. But the gastroenterologist is the one that specializes in diseases of the gastrointestinal tract. And what is that? That's the esophagus, it's the stomach, and when food leaves the stomach, it goes into the intestines. And it's also the biliary system where some enzymes and things are put in to help digest the food. Otolaryngologists, or most commonly called an ENT, ear, nose, and throat specialist, is just that. They specialize in the throat. So you might see an ENT if the problem is pharyngeal. Do be aware that some of them specialize. Like you might find an ENT, but what she works mostly on is ears or problems with the nose and allergy kind of things. So if you're seeing an ENT, you want to make sure it's someone who is familiar with dysphagia and the pharyngeal phase. And I would say the ENT is often the primary physician who's managing patients who've had head and neck cancer. Neurologists are those physicians that specialize in treatment of the disorders of the nervous system, brain, spinal cord, nerves. So things like stroke, multiple sclerosis, Parkinson's, head injury, Alzheimer's disease, ALS. There's probably not a neurological disorder you can think of that doesn't have the possibility of having dysphagia with it. And again, there are neurologists and there are pediatric neurologists. And again, finding the pediatric specialist can be challenging. Dentists, you guys know what dentists do because we all see dentists, but they are specialists in the oral cavity. So for an individual who's had, for example, surgery for head and neck cancer, maybe had their teeth pulled, the dentist may become a very important part of the team. Radiologists, they're the physicians that specialize in diagnosing and treating diseases and injuries with imaging techniques. So they do things like the CTs, the MRIs, PET scans, etc. They are also the specialists that speech-language pathologists work closely with when we're doing what's called a modified barium swallow or a video fluoroscopic eval. And then there are very specialized oncologists, so a radiation oncologist who delivers the radiation therapy and a medical oncologist that manages the medical aspect of cancers. Physical therapists, certainly in the pediatric population, physical therapists are an essential part of the treatment team. With adults, as well with any kind of neurological problem, or also perhaps with head and neck cancer, and they have swollen lymph nodes and need lymphedema drainage. There are different ways that a physical therapist might be involved on the team. Occupational therapists help restore functions the individual needs for daily living. So the ability to self-feed, for example, eye-hand coordination. They're very often involved in treating pediatric feeding and swallowing disorders. If the child has sensory issues, food aversion issues, then the OT may be the one who's most involved in addressing those sensor integration issues. Dietitians are the food and nutrition experts. They can determine what the person's going to need for adequate nutrition and hydration, help the person understand how to modify food textures. If tube feeding is involved, they're very important in managing tube feeding. And then there are other professionals who touch on the case. Teachers and early intervention specialists, developmental specialists in the pediatric population will likely have to help carry over any recommendations that are made. In healthcare situations, that may be nurses and nursing assistants. Now, the speech language pathologist role, I mentioned the place to start often is with a clinical swallowing evaluation, which involves a careful history taking, an assessment of the oral mechanism, the mouth and the throat, and then observing the person, assessing them with feeding. But the SLP does a lot of other things too. They do instrumental assessments when needed. I'm going to show you a couple examples of those. They can make referrals to some of these other medical professionals that we just talked about. They help make decisions on what's the best methodology for managing the swallowing and feeding disorder. They develop a treatment plan. They provide treatment, decide when it's time for discharge from treatment, provide teaching and counseling to individuals and their families as well. Educate other professionals on the need for management of swallowing and feeding. So you might find them doing, for example, an in-service to early intervention specialists or an in-service to nursing assistants, etc. They also should play a vital role in advocating for services for the individual with a swallowing or feeding disorder. So those of you who are speech language pathologists and listening to the webinar, you know that that's very much a part of what we do, which is helping the individual and their loved ones navigate what can often be a very confusing and complicated medical system and the education system as well if the child is in school. Well, how do you go about finding the right professional? Certainly word of mouth, so asking other individuals, who did you see? Did you like that person? Getting a referral from your primary care physician, scorecards on the web. I'll show you an example of one or two of those. And you also want to make sure you get the MD within the practice that you want, because you know who usually gets the new referrals. It's the new kid on the block. And a lot of times there's not anything wrong with that. But if you've identified a practice with a medical professional who really knows dysphagia, then that's the one you want to see. You can ask if they're board certified. Almost 90% of physicians practicing in the US are board certified. And you may want to drill down further. So we use the ENT as an example, that you might find a board certified ENT and find out that her practice is largely kids and tonsils. And that may not be the person that you want to see. You all find all kinds of things like this on the web. This is one called Health Grades. I give it just as an example of a scorecard. This one, these are people in South Florida. So you get a score. Here's a 3.60, here's a 4.80. I think you also want to look at the number of ratings. So 44 people rated this Dr. Parnas, 85 rated Dr. Aronson, and 310 rated Dr. Martinez. because I think that tells you something as well. It tells you how busy they are, but also if we know anything about statistics, we're probably going to figure a little bit more confidence in a rating that was averaged over 300 people. And then I like to read the comments, because sometimes somebody's got a low rating just because their office staff is slow. You also want to make sure that if you get on this person's page, but you drill down, because you might find a statement on there that says taking new patients, and then you call the office and they say, well, no, this doctor's not taking new patients, but the new partner is. So then you have to decide if the new partner is okay and that's who you want to see, or do you want to find another practice with a specialist where the person taking new patients is the one you want to see. Speech language pathologists are also board certified. You can go to the website of the American Board of Swallowing and Swallowing Disorders, and the last line on this slide on the left lists the URL to find that. And when you get to the site over here on the right, you see where it says find a specialist, and you can put in the area that you're in. You can put in whether you want somebody that works with kids or with adults, and find individuals in that way. Once you identify a provider, you want to have a conversation with them. And you want to ask, and some of these questions you can ask of the person that you're talking to when you're scheduling. What percent of your caseload or your practice is whatever, somebody else with esophageal dysphagia, or children under the age of 9 months, or whatever that is that you want to kind of hone in on. How many years have you treated patients with dysphagia? Am I going to see you, or am I going to see a physician's assistant or a nurse practitioner? Now, again, that's not necessarily bad. I don't know about you, but I find that often the extenders listen more carefully and spend more time with you, but also they're not going to have the expertise as the physician. You may also say, if I have questions between visits, can I reach you, and how do I reach you? And we shouldn't be afraid to ask these questions. And if you found a provider who gets snippy and don't want to answer those questions, I'm going to suggest that maybe that's not the best provider for you. I found these tips on a Patient Advocate Foundation of why you might want to seek a second opinion. It can help you feel empowered and take control. If you've ever had a medical diagnosis, knowing that 2 different physicians found the same thing can help you feel empowered, can give you some peace of mind. You might want to seek a second opinion when you've been told by your current provider, look, there's no other options, I don't know what else to do. Then seek a second opinion. You find a provider you like and you trust, and one that you feel like has a good understanding of the problem. You're not obligated to stick with the first one you see. And a good provider will understand that you may want another opinion. They should not be threatened by it. They should absolutely understand that sometimes 2 heads are better than 1. What kind of tests and procedures might you be involved with? I mentioned this clinical assessment already by the speech language pathologist and the different things that might be covered there. And then there are some instrumental assessments. Now remember the video we saw, the second video, where we saw the food moving through the throat. So there are basically two studies that are most in use to look at that phase. I'll mention a few newer ones that are coming out. But there's a video fluoroscopic swallowing study. That's an X-ray study, commonly called modified barium swallow. And then there's a fiber optic done by an endoscope evaluation of swallowing. And why would we do that? Well, because we don't have X-ray vision and we can't tell what's really happening in the throat. So if we need to see the movements of the throat, whether there is any aspiration occurring, if there's residue there, if we need to change something to make swallowing safer or more efficient, we may definitely need to see what's going on in the pharyngeal phase. Sometimes we'll ask for an instrumental if it's just a diagnosis that's a high risk, like a child with let's say cerebral palsy or multiple handicaps. Maybe I'm evaluating a person who has some cognitive impairments, maybe secondary to a stroke or Alzheimer's disease, and they can't adequately follow directions for the clinical exam. I may need an instrumental so I can get a better look at the swallowing in the pharyngeal phase. This is one that I mentioned, and you can see here that she's holding an endoscope, this in a pediatric patient. So that scope goes in the nose and hangs down right in the back of the throat. In kids, it's often done with an ENT, and it's often the ENT who actually places the scope, although it certainly could be an experienced SLP placing the scope. With adults, it's almost always the speech-language pathologist placing the scope, and there's probably not a physician involved. Now, I'm just going to give you a little example of a view with that endoscope. So pretend you've walked in the mouth and you're looking over the back. Down there, that little V are the vocal folds. You can see how everything closes. We'll run it one more time. So that would be the airway. We don't want food to go there. This movement is the person chewing. They push the food over and it kind of whites out because everything was closed and the scope couldn't see. So that's just an example of what an endoscopic view might look like. The modified barium swallow is an X-ray procedure. This piece of equipment would actually be rotated so that, let me think, 90 degrees. Now, this is what that kind of study looks like. The person swallows barium, which is the stuff that looks black. You kind of compare that to the animation that I showed you. So that's an example of a modified barium swallow or BCS-S video fluoroscopic swallowing study. Here's an example of an infant with that kind of exam. And again, we're not going to comment on whether these are normal, not normal. That would certainly be beyond the scope of this webinar for sure. And then there are lots of other studies. I'll show you a barium swallow in just a minute. Those are more X-ray procedures, the barium swallow in the upper GI. There are other procedures with the endoscope, esophagoscopy, but the scope goes much lower down into the esophagus. Manometry is increasing in use now. It measures pressures and movement. And then there are some procedures for assessing how bad the gastroesophageal reflux is, the GERD is. This is an example of a barium swallow. This is a front to back view or an AP view. So instead of focusing there on the throat, it follows the bolus as it moves through the esophagus and then into the stomach. That's that sphincter right there that we talked about, and this is the esophagus here. Okay, so let's say you are referred for a procedure. Here are some questions that I would hope you would ask whoever's referring you. The speech-language pathologist, your primary care physician, the neurologist. Hey, what do we hope to learn from this procedure? And are there any alternatives to the procedure you're recommending? What are the risks? Where's the best place to have the procedure done? When will I learn the results? And I'm sure you can think of others. And if so, drop them in that Q&A box and we'll share them at the end. But don't be afraid to ask these questions. You know, why we don't want to do procedures just to be doing them. So what do we hope to learn here? Then for the person who's actually performing the procedure, so maybe it's one of those imaging studies and you want to ask the radiologist, can you explain to me exactly how the procedure is done? You know, too many times that you're shown into a procedure room, you've got the gown on, the person performing says, hop up here, lay on your side, hold your breath, whatever it is they need us to do. But don't be afraid to also say to this, can you explain to me how this procedure is done? What do you hope to learn from the procedure? Now, if it's something being done by a non-MD, a technologist, they're not going to tell you what they hope to learn. Now, the exception is the speech-language pathologist, although not a physician, should be able to tell you what they want to learn from either that video study or the endoscopic study, and they should be telling you the results. But for example, let's say you've gone for a breathing test with a respiratory therapist. They may say to you, the physician hopes to find out what your lung capacity is, or the radiology technologist may say, this study has been ordered to determine if you have a stricture. But they're probably not going to go into a lot of detail. It's just a different relationship. Certainly it's fair to ask, when will the results go to my physician? Be sure you tell them any other physicians you want it to go to if they don't ask. So they may have listed there the referring physician. Let's say that might have been the neurologist, but be sure you tell them, hey, I also want this to go to my primary care physician, or I also want this to go to the pediatrician. And then how do you get a copy of the results? If medications are prescribed, you want to ask questions like, what are the desired effects, and what are the common side effects, and what are the less common but perhaps more serious side effects? How should I take this medication? Like the time of day, with or without food? Does it interact with any other meds? It's interesting that there's an orange in the background, because oranges are fine, but you know, lots of meds don't work well if you eat grapefruit. So, you know, that's why you want to ask, what kind of food can I take this with? And what'll happen if I choose not to take the medication that you are recommending? Surgeries might be involved with the oral phase with kids, very young kids. They might have tongue tie, or the official term is ankylosing. So they might have that little tissue under their tongue clip. That's an example. There are tons of other surgeries, but these are examples. For pharyngeal dysphagia, if the vocal folds aren't moving together well, they might move one more toward midline. For esophageal dysphagia, they can do dilation, where they stretch it if it's narrowed. They can cut the muscle. If there's a pouch that's kind of pooched out there, a diverticulum, they can surgically close that. If reflux is really, really bad, they can do something called a Nissen. There's lots of surgeries. But boy, when somebody's going to recommend a surgery, then we're really going to start asking questions. What do we hope to gain from this surgery? And are there any alternatives to the surgery? What are the risks of surgery? What are the downsides to not having the surgery? Where's the best place to have the surgery done? How many of these surgeries has this particular surgeon performed, and what's the success rate of the surgery? How do you get ready for a medical appointment, and how do you keep track of things? Well, certainly there's old school paper copies, nothing wrong with that, or you might use a patient portal, or as I found out, a lot of physicians' patient portals, there's nothing there. So you want to ask, if they say, here's our patient portal, then I want to know, well, are your notes going to be in there? Are the copies of my labs going to be in there? This is a timeline I used to deal with a medical problem that I was dealing with. And I have made an example here, but I update this after everything that's gone on in my health. And I think it's good. I don't know about you, but if a physician says, well, when was the last time you had a chest x-ray? I'm like, I don't know. Or when was your last tetanus shot? So I just have a little chart like this that I keep on my computer with the date, the type of visit, who the doc was, and what the notes were. So, you know, if that's helpful to you, feel free to use something like that. Before you go to any visit, make a list of the questions you have for the visit and write them down and leave a space for the answers. I think this serves a couple of purposes. One, when most of us get in a physician's office, number one, we feel a bit rushed in most physicians' offices, and it's nerve-wracking. And so you may have gone in knowing exactly the 5 questions you wanted to ask, and sure enough, you and the physician get off on a discussion, and he's like, he or she's like, anything else? And they're out the door and you're like, oh, as soon as you get in the car in the parking lot, you're like, I didn't ask XYZ. Another purpose I think it serves is when you go in with a notebook and a pen, or if you're real computer savvy, take your laptop in there. And the physician sees that you've come in with questions. I think it sends a message that I really want this information and I have some questions that I'm going to ask you, and I really need you to help me answer these questions. Bring a support person. A second set of ears never hurt anybody. Number one, it's helps keep you calm. Somebody else is there. And if you're dealing with a medical issue, whether it's not that serious or serious, sometimes you shut down. You can't hear the things that are being said. So bringing a second set of ears, maybe even somebody else that's taking notes in the medical appointment. And then be sure you update your records. You can use that document I showed you where you put a new row in. You can go to the patient portal to get your records. And then as you're looking at the records, if you think of questions, pull your notebook out and jot them down. Or if you use your phone, put your questions in your phone and jot them down so that you're ready for the next time. Now, a couple of the things I'm going to cover here at the end of this webinar were generated when, as Elizabeth said, sometimes I sub in on the support groups. And some of these are the questions that have come up in the support groups. And that is, what happens if they don't find what's causing your dysphagia? The things I'm going to suggest are also, however, good just before your initial visit with any physician or provider. Do some research. So get on the web, or if you're not web savvy, get somebody in your family or a neighbor or friend to help, and start looking for information about swallowing problems that have symptoms similar to yours. Be sure you are on reliable websites, Mayo Clinic, Medicine.net, WebMD. So, let's just say you don't want to do some research on Facebook or social media. Go to reliable sites. You might find a particular research study that you want to read, and if so, bring it the next time. I think nothing has a physician sit up a little straighter than you say, hey, I found this article in the journal in JAMA and I want to go over it with you. And if you're not a person that wants to read those kind of studies, that's fine. You can print out a web page to say, I read this on WebMD and it sounded similar to my problem. Can we talk about it? Observe yourself, or if it's someone, your loved one, observe them and make notes of anything the person does or any circumstances that make the swallowing or feeding problem better or worse. Better or worse at certain times of the day or night, relieved or made worse with certain foods, temperatures of food, tastes of foods, etc. Better or worse when sitting, standing, lying down. Anything you can think of that might have changed will help the professional hone in on why this diagnosis hasn't been nailed down yet. Then schedule a meeting. You've done some research here. You've got your questions written down. And again, this is a case of if your diagnosis hasn't been made, but also it's not a bad thing to do before your first visit. Sit down, schedule a meeting, and go over all your prescriptions. Not just that, but your over-the-counter meds. There are so many drug interactions, and unfortunately, most of the time there's not a good discussion about, oh, you're taking that? Wait a minute, that might be causing the dry mouth that's causing all the trouble. If you're having any other medical problems or have had in the past, be sure you bring them up. Don't make the mistake of thinking, well, that can't possibly be related to a swallowing problem. For example, maybe you're feeling a lump in the throat and you think, well, I'm not sure I want to mention that. Or I have indigestion. How could that be related to this feeling up here? Well, they might be related. Or, boy, my voice is really hoarse. I've been straining to talk, and you're thinking, well, that can't be related to swallowing. Well, you know what? It might be. Something as unrelated as my handwriting has really gotten shaky over the last 3 or 4 months. That might be an early indication, for example, of a neurological problem. So any other things, even if they seem random, share them. And then ask some other questions. Are there any other diagnostic tests maybe that I could have that would help gain information? What are those tests and what might they tell us? Have you ever seen another person that had symptoms like mine? Yes. Do you have another medical professional you could consult that maybe has seen somebody with a problem like this? If you have anxiety about the problem, be sure you talk about how that is affecting you and whether or not it makes your symptoms worse. You might seek out a multidisciplinary swallowing center. They might be called Swallowing Clinic, Swallowing Center, Voice and Swallowing Center, Dysphagia Center, because at these specialized centers, and they're usually at a hospital, and often, not always, with a large university system, there'll be a multidisciplinary team. So if you're having trouble getting an accurate diagnosis, going to a place that has all these different professionals may be very helpful. And you're going to have an ongoing treatment team if it's a dysphagia or a feeding problem that needs treatment. And the ones that are going to probably be those you see on a regular basis are the speech-language pathologist, OT, probably PT and a kiddo educational professionals. What if you have to change professions? Maybe you're moving. How do you communicate past information? I had a parent share with me one time they were a little concerned that the new therapist might form an opinion just reading records and not really get a good feel for the child. So here's an example between a caregiver and a new medical professional. Mandy's real strengths are, her biggest challenges are, some misperceptions therapists have had in the past, and you decide if you're going to share, if that's important for you to share. Hey, here's how I communicated in the past with our therapist on how she's doing at home. Does that work for you? How else would you like me to share information? In the past, it was helpful to me to get information from Mandy's treatment team in this way, phone, text, whatever. What's a reasonable expectation before I'll get written reports? How can I be helpful to the treatment team? And I know sometimes mothers have blinders on and not see things that the therapist sees. Will you tell me if you think I'm not being objective? I know as a therapist, I would welcome an open conversation like that. What if you can't find a board-certified speech-language pathologist for that treatment team? Contact a facility near you. You can go on ASHA's webpage, the American Speech Language Hearing Association. Find a list of practices, and these will be practices and clinics, and not necessarily with board certified. And then you call a facility and you say, can I speak to your speech language pathologist who treats swallowing disorders or who treats feeding disorders? And ask them some questions. How long have you been a certified speech language pathologist? What percent of the time is spent working with children or with adults with feeding and swallowing disorders? What types of problems have you treated? And then you describe your challenge or your child's challenge and ask what the SLP's first steps would be in evaluating the problem. And that's going to kind of give you a feel for, I think I got somebody here who knows what they're doing. A lot of us don't live in a big metropolitan area where you can find the highly skilled professional near you. So consider what I would call a hybrid model with the therapist that you see maybe every 3 months or maybe monthly, and a therapist closer to home for ongoing treatment. Not every speech language pathologist, not every OT, not every PT, not every physician is the best one to treat you or to treat your child. Our code of ethics says we shouldn't treat somebody if we don't have the skills for it. But a hybrid model can work nicely where the more experienced person outlines the treatment plan, works closely over the phone with the treating therapist, and then periodically you go back to see the expert. So I'm going to stop there, and I think we have a few minutes for questions. Ms. Elizabeth.
Yes, Nancy, thank you. So much good information in there and so many good pointers. No matter where you're at in your dysphagia journey, some things to consider. We have a couple questions here. You've done a great job explaining things, so there's not a ton of questions, but I wanted to start with one here. Wondering if you could speak to the teach back method and what that is and how SLPs might implement that in a session.
Absolutely. I love it. I love the teach back method. So the teach back method is, so I'm the therapist and I'm explaining. So here's a technique I want you to try with me, and we go through the steps, okay? So let's just use one called the supraglottic swallow. I need you to take a breath in and let a little out. Now hold your breath really tight. That's it. That's good. Swallow real hard and then breathe. Now you be the therapist and show me how to do it. Or if there's a loved one in the room, why don't you show your partner here how to do it? And if they're explaining it really well enough for the other person to do it, you know you've gotten through to them. And it's not, it can be a very respectful method to use. So you're not saying, I don't think you really got it. Can you explain? You're saying, you did that great. Now let's just do it again, but you be the therapist and you explain. You can even have the significant other. Can you go through the steps for me? And if they're able to do that, and then you can say, oh, God, that was really good, great. Now, the one thing I think that you forgot was just take a little breath, whatever. Let's go through it again. So teach back is a fantastic method, and it's really easy to use. It can be even something as simple as, all right, what I want you to practice this week is every day, 10 minutes, you're giving out the schedule. You can teach back with that. So what is the schedule that you're going to try to practice these exercises on? So I love the method, and you can find easily information on it on the web.
Excellent. Thanks, Nancy, for mentioning that. We have another question here from, I assume it's a student, asking if clinical fellows are ever hired into the acute care setting without swallow experience from their grad internship. So if not, what can they do to try to get a clinical fellowship position? And maybe explain what a clinical fellowship is too.
All right, so when we first get our master's degree and we're out, our first 9 months of supervised work is called a clinical fellowship year, and we're more closely supervised because when we get out of school, we know a lot, but there's a lot we don't know, as in any profession, where you have to really have a kind of a coach. It really is going to depend on the acute care facility. If they do lots of different things, they have somebody who's more language and somebody who's more stuttering, etc. They may pull somebody in who has not had swallowing experience in an externship. And when you hire on, I think you would want to say, I want to do whatever I can to get the experience I did not get in my externship. And you may have to go above and beyond. Like, I'd like to stay an hour extra every day, or if I could work a weekend and tag with the therapist who does swallowing. I think you're going to have to go above and beyond, because with most acute care facilities, there's a lot of swallowing. So they are going to want somebody that can hit the ground running. But I think it's doable. Now, it depends on the size of the facility too. Let's say there's 2 SLPs and they're bringing on a third, and the whole thing is dysphagia pretty much. They're going to want somebody else that can hit the ground running. So I would look for a facility where they might have some outpatient work you can do that you're more prepared for, and then go above and beyond to try to get some swallowing experience.
Nancy, appreciate that. I have another question here for you. We get a lot of emails from community members saying that they have a fear of swallowing that sometimes stems from a traumatic event, but sometimes it's an unknown cause, and they feel dismissed by their medical team, even their PCP, where they don't get a referral to another specialist. What would you do in that case where the provider says, I think it's all in your head? And that's a direct quote from an email that we received just this week.
Right, and you know what, that points out that I really should have had another professional on that team, and that is psychologist and counselor. Fear of swallowing is a very real thing, and we do know that anxiety can actually cause physical problems. So Number one, I think you'd want to maybe talk to a different provider. Shame on them for making you feel bad that there's nothing wrong with you. It's all in your head. Well, you know what? My head controls everything in my body. And right now my head is making it hard for me to swallow. So it would be entirely appropriate to get a referral to a mental health professional and have that mental health professional talk to maybe the speech language pathologist who says, yeah, we did a study, there's not anything wrong. And I certainly saw people over the course of my career where there wasn't anything physically wrong, and it was all related to anxiety, which can cause the muscles not to do what you want them to do. So yeah, definitely seek out a mental health professional, talk with them about anxiety and how the anxiety, because you know, anxiety can manifest as headaches, anxiety can manifest as backaches when there's not a muscular problem. So yeah, mental health professional would be entirely appropriate to address that with.
Excellent. Thanks for touching on that. I want to read one comment out loud here for you, and I think this is important too for the providers that are on this call. The comment says, I really liked how you emphasized the importance of patient, family, and parent choice. Also the importance of the healthcare provider to listen and take the time to explain things in everyday terms. Yes.
Absolutely. I think all of us are intimidated in a medical situation. And it doesn't matter if, you know, I worked in a hospital my whole career. You drop me into a pulmonologist's office to take a look at my asthma, and all of a sudden I'm like, oh, I can't. Yeah. And as providers, we should do everything we can to make the person feel comfortable. There aren't any dumb questions. You know, we take so much for granted because we know about swallowing, and ENT knows so much about, but we shouldn't feel bad as consumers to say, back up a little bit. Now what? Explain that again. And a good provider will do it. They should be happy to help you understand.
Thanks. One question here, wondering if you could go back to your first slide on the role of the SLP, if you're able to scroll back through your slide deck.
Yep, I should be able to do that.
Excellent.
Let's do this. All right, how about here? Okay, so that's the first one, SLP's role. Can you guys see that?
Yep.
Okay, so let me know if there's something specific on there that you want me to address.
Sounds good. I don't see anything yet, but I will let you know.
Okay.
And so far we have addressed all of the questions. If there's any other question that anybody has, feel free to type it in, or if you'd rather email it to us, I'm happy to get that to Nancy. So please feel free to email us questions. Otherwise, we'll wrap things up if that's okay with you, Nancy.
Absolutely, absolutely. And I am happy to have questions. My email is on there, and yeah, interact with anybody. So.
Thank you again for presenting. This was such good information. We really appreciate it. If you missed any part, we'll have the recording available on our website, along with the slide deck that you can download too from either the toolbar here, or we'll make that available through our website for you. Nancy, thank you for taking the time to volunteer. We so appreciate that. If anybody is interested in joining our virtual support groups, I'll send out more information. Again, that's for people with swallowing problems and also for their loved ones. If you're a speech language pathologist on the call or another healthcare provider, we have different educational opportunities available for you as well. I will send out a certificate of participation tomorrow along with a survey that you can fill out. It's optional and takes less than 5 minutes to complete, but it is really helpful for our organization as we continue to plan out more TAD Talks. Starting in February, we are launching a new webinar series called Meet the Maker, where we are inviting different companies and organizations that make dysphagia treatment products to come and showcase their product, to explain what it's used for, who it's designed for. You're welcome to join those. They will be free, and I'll send out more information on that. And with that, we'll wrap out tonight. Nancy, again, thank you. Everybody else, thank you for taking the time to join us, and hopefully we'll see you again soon.
Thank you.